Hey there, it's time to take the lead. Trust your voice, know what you need. Let's break it down.
Welcome to Beyond Clinical Walls with your host, Dr. Bayo.
Claim your life.
Picture this. Your loved one has just been diagnosed with a serious illness. The doctor mentions palliative care, and suddenly the room gets quiet. Everyone shifts uncomfortably in their chairs. You're left wondering, does this mean we're giving up? Is this the same as hospice? What does this mean for our family? The truth is, most of us have never been taught what these terms really mean or how to navigate these conversations when they matter most. Today's guest is a palliative care specialist who's dedicated his career to making sure families never have to face these decisions feeling lost or unprepared. If you are new here and you've landed on this episode, I'm Dr. Bayo, your health advocate. I'm a board-certified family medicine physician, and I bring the work I do seeing patients with me on the news, on social media, and here on this podcast. I'm so grateful to be doing this episode because I had the opportunity to do a few rotations with both hospice and palliative care, and absolutely loved that experience. There's something profound about being part of these vulnerable and empowering conversations that help families find clarity and peace during some of life's most challenging moments. By the end of this episode, you'll have a clearer picture of what palliative care really is, why it matters, and how it can help you and your family face tough moments with less fear and more confidence. Today, I'm joined by Dr. Matthew Tyler. Dr. Tyler is a dual board certified in internal medicine and hospice and palliative medicine with over a decade of experience caring for patients and families navigating serious illnesses like cancer, dementia, and heart failure. Dr. Tyler is the founder of How to Train Your Doctor, a platform reaching hundreds of thousands across platforms that guide patients and families through high-stake decisions about their health and quality of life. His goal is to make sure no one faces those choices alone or unprepared. Dr. Tyler, welcome to the show.
Hey, thank you so much for having me. It's great to be here.
Well, I am so excited to have you. Well, if you're game for it, I'd like to start with some rapid fire questions.
All right, let's do it.
All right. So first, what made you specialize in palliative medicine?
Well, I found palliative care by accident, like so many other folks, both in the medical and non-medical world. I had not heard of palliative medicine when I started my residency training. I happened to have an elective rotation in palliative care like you, and I got to see firsthand how palliative care really flips the healthcare delivery model that we're typically used to seeing. The typical model being, here's what's wrong with you, here's what you need to do. Whereas palliative care says, okay, here's what we're dealing with, but what can we do for you? And it really is a model that puts the patient at the center. You know, the stories the patient comes with, their life experience, what's important to them emotionally, spiritually, all that gets integrated into the care plan in a way that I had never seen before. And the minute I did, I said, I have to do this. So from intern year on, I was the guy gunning for the palliative care fellowship, and the rest is history.
Fantastic. Coffee order of choice.
Black coffee, cold if it's hot out, hot if it's cold out.
Hey, I love that. I am black coffee as well.
Yeah.
One lesson about life you're sharing with your loved ones.
Maybe less sharing and more doing, but just showing up. We're in a season of life now where we are beginning to more concretely appreciate how important it is to have people in your community, people that you call family, both your blood relatives and the people in your neighborhood. And we are really making stronger efforts these days to do the Friday night dinner with friends, just show up for other people's kids' events, the birthday parties, things that, as you know, you kind of have to put on the back burner through training. Whereas now, those are the front burner things now, really just showing up and being present in people's lives and enjoying the season that we're in.
That's beautiful. Best thing to say to someone facing a serious illness?
Oftentimes it's nothing. It's just being there and being present. But just, how are you doing? And really meaning it and being present to listen to the answer goes a long way.
What is the most common regret people often have when they get a life-changing diagnosis?
It's a hard one. I get lots of different answers. I think the most common theme I will hear is that of time, how time was spent, who time was spent with, whether, not enough time with one person or too much time with another person. And a lot of our minds tend to drift towards family and our loved ones and always wanting more time with them.
So now we're going to kind of dive deep. That's the way I want to kind of describe this into this conversation. That is a conversation that I think should be a part of every family, every person that you should have with yourself as well, because these types of situations that can happen at any moment in time. But if you are prepared, it's amazing how navigating a serious illness, a condition, a complication that you never expected can make the difference. So let's first start off with what made you create How to Train Your Doctor and start educating people about navigating serious illness?
Yeah. How to Train Your Doctor came about after making a few observations of recurrent themes I would see in the hospital. As a quick background, I practice palliative medicine full time. I see patients both in the hospital and in our cancer treatment center. But the bulk of my work is with folks who are hospitalized due to flare-ups of any number of serious illnesses like congestive heart failure, chronic lung disease, advanced stage cancers. And so something has happened to land them in the hospital, and often I get involved to help them make fairly complicated, complex decisions about their health, where medically speaking, there may not be a strict right or wrong answer about how we proceed, and how we proceed is heavily dependent on the person and their preferences and priorities. And often when I would be at the bedside with families, I would hear a couple of things. One is they would often just not know what to ask or what to say. Often you're kind of overwhelmed with everything going on and then being asked to have a very complicated conversation, emotionally charged. A lot of people aren't able to do that. Many could, and the ones who could would often ask, where have you been? Like, why am I just meeting you now, like at the 11th hour? Where have you been up until now? We really could have used your support a long time ago. So I wanted to help people prepare for moments like that and to help people train themselves to think about these things before a crisis, be prepared for difficult decisions before they got into a crisis where you're overwhelmed, and pretty much in the worst possible time to have a complicated high stakes conversation is when you're overwhelmed and in a deer in headlights. I wanted to start having that conversation in the public and normalize those conversations. And for those who maybe aren't able to have that conversation or not sure how to have that conversation, at the very least, educate more about palliative care and what it is and what it's not. So even if you're not at a point where you can start having these conversations, at the very least, you know to ask for a palliative care consult and know when to push back if someone tells you it's not time for a palliative consult, which is rarely the case, but told to people quite a lot.
And that,
Yeah.
well, and that leads me into, let's talk about what is palliative care and what is hospice care, because a lot of times people have no idea. And I would love for you to also share, after we describe it, what are the most harmful myths you hear about palliative care?
So palliative care is a type of care that is patient-focused and provides an extra layer of support to help you cope with the symptoms and stressors of any serious illness to help you have the best quality of life possible. It's a team-based type of care that includes every discipline from docs to nurses, chaplains, social workers, therapists. It includes your family, those closest to you, and you as the patient at the center of that team. And palliative medicine is a medical subspecialty that implements palliative care models into our practice of medicine as physicians. And by far what's key and what's often kind of caught up in like the myths of palliative care is that palliative care is the same thing as hospice. And really the key that everyone needs to know is that you can get palliative care alongside your disease-focused treatments. You can get palliative care while you're going for a cure or remission, so long as you have a serious illness that is threatening to your quality of life. palliative care should be on the table for, your options and a source of support for you. So by far the biggest myth is that palliative care and hospice are the same thing. One of the most harmful misconceptions is kind of using palliative care and hospice in the same breath. Whereas hospice is specialized and end of life care for folks in the last 6 months of their lives, and for people who specifically want to pursue comfort exclusive care. And we're at a point where disease focused treatments just aren't really helping people live the life they want to live anymore, and they want to, by and large, allow nature to run its course with the best comfort care possible. That's hospice care, which I think of as a subset of palliative care, whereas palliative care is a larger umbrella of specialized supports wherever your prognosis happens to be.
That is a great way to define it. A lot of people aren't aware that if you do have a complicated disease condition that you're facing that does impact or could impact your quality of life, that you can ask for palliative care. And as a family medicine doctor, that's why I appreciate you guys so much. All the work that you do, and the fact that the patient is center, and it really represents a patient-centered home, because you have all of the services. And you mentioned medicine is a team sport, and why not have a group of individuals really centered on your care to help you get through this with whatever you decide is best for you is huge. And that brings me to one thing. You're an advocate in so many different ways, but I'd love for you to talk about how you advocate for newlyweds to have healthcare conversations before a crisis occurs. Can you walk us through why this is important and what we should talk about?
Yeah, so I made a video about this recently that was prompted by Taylor Swift's engagement. Marriage is an interesting, it's an important season of life. Things are changing, family dynamics are changing for many folks. So on one hand, getting married in most states has implications for who your default medical decision maker is. What many folks may not realize is that if you get very sick and incapacitated to the degree that you cannot tell your medical team what to do, you can't guide them about what decisions to make. First we look to see if you have already signed a healthcare power of attorney, or someone you have legally designated as your proxy decision maker to step in when you can't tell us what to do. If you don't have that documentation in place, most states have a very clear protocol, statute in place with a hierarchy of who steps in. And typically it goes, presuming you don't have a legal guardian, who's always going to top of the list there, but legal spouse is next on the list. And then it's usually adult children, then parents, then siblings. You kind of want to double check your state laws to know the exact protocol. But when you get married, that fiance, now spouse, jumps up to the top of the list, whereas it may have been your children or your parents or your siblings before. And I think for many people, they are perfectly fine with their spouse being their medical decision maker. For some folks, maybe that's not the best person for them. Maybe they worry about their spouse being overwhelmed or being unable to step up and advocate for the end of life care that you want for yourself, or maybe you just don't want to burden them with that, because that's a terrible decision to have to make for a spouse or anyone for that matter. I think that practicality of a new person in your life kind of stepping up as a default decision maker is a great opportunity to take a beat and just have a bigger discussion in general with your loved ones, your spouse, your family. Just check in and say, hey, with this change, I want to touch base and make sure that we have a clear protocol of who would make decisions for me, what's most important to me. Here are factors that go into my quality of life that I want everyone to know about. Just start to build that muscle and normalize these discussions, and not wait for a crisis 30, 40, 50 years from now. Just integrate that into the conversation, and also just get in front of any potential conflicts about who would be speaking for you, who would step in, how do you want that to go out, just so they can all hear in your words that these are your wishes, at least when it comes to your surrogate decision maker, and then down the road, maybe more specific wishes about your care itself.
I often share that if you have the opportunity to have a clear, concise discussion with your loved one about what they would like, why not have it before a crisis happens? Because that's when you can really absorb and take in what they would like, or what would be the plan if you faced a crisis or something, because we never know. That terminology is often talked about, live life to the fullest. You never know what could happen. Well, We don't, but what we do know what we could do is really have a plan in place. And that starts with that discussion in all areas, whether it's a season of a marriage, having a new baby, any of those things, these types of conversations can be vital. And that brings me into, you had mentioned palliative care and how it can be essential when you are facing a complex condition, diagnosis, even cancer. Can you walk me through how someone would be able to even ask for that to be part of their care, and what does it look like if you are, let's say you are someone who just received a cancer diagnosis and you would like to now have palliative care? What would that look like?
So this sounds like a two-part. How do you get palliative care, and then what would that initial talk with me sound like as a patient? For most folks, getting connected to palliative care can be as simple as just asking your main physician for that referral, whether that be your primary care doctor, your oncologist, your cardiologist. Depending on how savvy they are with palliative care and how well they distinguish palliative care from hospice, you may need to explicitly tell them, I am not asking for a hospice referral. I'm asking for a palliative care referral. My quality of life is important to me. I could use a little extra support as I navigate these things. Can you help me out with a referral? Depending on your insurance plan, again, so part and parcel to this, people will often ask me, well, who pays for palliative care? How does that work with insurance? And for most folks, palliative care is going to work the same way. Any specialty would be covered under your insurance plan. Similarly, how you get access to specialty care depends on your insurance. Some folks can self-refer. Some plans like Medicare Advantage, you do need the actual referral from your physician. So some people have to deal with the gatekeeping more than others, unfortunately. But if you're looking to see what is in your area, there is a great resource called getpalliativecare.org that has a palliative provider directory and on kind of the front page there. And you can type in your zip code and see what's around. So maybe doing a little legwork ahead of that visit with your doc to say, hey, like I've been looking up this group, sounds perfect. It sounds like they would work really nicely with you and be an extra layer of support to help us out, help us work together better. May help, do an evaluation for symptom management needs, whatever, kind of have that name, say, hey, can you just send the referral out to them, kind of make things nice and easy. So that would be how we kind of work on getting access to palliative care. For an initial palliative care referral, a lot of the highlights of what I might cover on the first visit, the first and foremost would depend on what are you as the patient hoping to talk about right now? Do you have any pressing needs? Meaning like if you're in a pain crisis right now and you really need to get under control, that will be my focus, right? We're going to want to get any major physical symptoms tamped down first. But putting that aside, if we're kind of doing kind of a head to toe type of visits, figuratively speaking, I'm going to be trying to get a sense of what your illness understanding is. What have you heard from your doctors? What expectations have they set for what treatment will achieve? What are your goals with treatment? What are you hoping to do with the treatment? What's most important to you? What are you hoping for? What are you worried about? Exploring that to whatever degree you feel comfortable doing, which is often based on kind of how well you're coping, which I'll want to get a sense of too, and how your mood is. And then we'll go through any symptom management needs that you want to work on: pain, nausea, fatigue, constipation, working on optimizing that. And then just getting to know more you as a person. Like, what are you doing outside a clinic, outside the hospital? What's a typical day like? Like, who's in your world? Who's in your circle? Who are the most important people in your life? And where do you draw strength from? Whether that be your family, your job, your faith. Kind of getting a sense of, what those anchors are in your world and how we can kind of reinforce those. And then practically speaking, do you have wishes in writing already? Do we have them on file? Do you want to put stuff in writing? And kind of talking you through the various advanced directives like healthcare power of attorney that we mentioned before, a living will, a do not resuscitate order, again, to whatever extent you find helpful and empowering to have those in place. So that's a kind of very high level kind of overview of things that we might talk about. I largely will kind of let you as the patient guide, what is most important to you and what do you want to focus on. But if you don't come with any particular agenda, those are some of the things that we might touch on in any given visit.
I love that. Here's a reality check. The Conversation Project shows that around 90% of Americans believe it's important to discuss end-of-life wishes with loved ones. Only about 27% of people actually have had these conversations. Dr. Tyler, let's get into advanced directives and living wills. Who should have them? What should they include? And how do you have those conversations before you're in a crisis? For anyone who's been hospitalized and you all of a sudden have a doctor ask you these standard questions about resuscitation, if your heart stops, can you break down what families should actually understand about this decision? Because it can be really hard to process.
Yeah, that is very much dependent on the individual health factors and how much time you've had to live with this illness versus a brand new diagnosis. I think depending on the individual, you can come at this from any number of ways. A helpful starting point for many people has to do with how motivated are you to want to deviate from the default medical pathway. And by that, I mean, you get swept up in any diagnosis, and there's a default pathway of procedures, testing, treatments, rinse, repeats, hospitalization, clinic visits, all of it in service of the presumed goal, which is keep you alive as long as possible, regardless of what condition you're in or what your quality of life happens to be. For some folks, that's what they're going for too. That their goal is life extension to the greatest extent possible, and their quality of life is secondary or not even a consideration at all. So there are some folks for whom getting wishes in place maybe doesn't feel very necessary for them. So for folks who speaking in advance, documenting wishes in advance makes more sense for it, I would say, are the people who know at least at some point down the road, they have a line in the sand where they would draw to say, this isn't living anymore. I draw a difference between just living versus being alive and enjoying my life as a human being. If you've got a line like that, it is very helpful to talk about that with yourself. You've got to reflect personally on that with your family to help them understand what living means to you, what matters most to you, and where you can document that. And this ties back into what we were saying about newlyweds, that same thing with healthcare power of attorney. Again, if you don't do a healthcare power of attorney, there is a default process in place for someone who will speak on your behalf, and you're okay with that default, then from a medical point of view, a healthcare power of attorney may not feel necessary, but from kind of a logistics point of view and giving someone kind of full access to medical records and access to the medical team, it may still make sense to codify that with a healthcare power of attorney. All that said, there is a bit of a spicy debate in the palliative care world these past few years about advanced care planning and really the benefit of sitting down and talking about your wishes and how that impacts your care. Some folks feel very strongly that this is a value, it changes care. Other folks are looking at the data and saying, we haven't exactly proven that talking about your wishes and putting them in writing really changes the care that you would get even if you didn't do that. And I think a lot of that has to do with what I was just saying. A lot of it depends on your motivations and how you approach your care. And if you're someone who feels strongly about quality of life and drawing a line in the sand, there's a good chance you're going to find the care that you want, regardless of whether or not you've put wishes in writing or not. You probably are going to build your village either way, regardless of what the papers say. But I think there is still value in talking about what's important to you, more so from a values point of view, a priorities point of view, rather than medical wishes. I do, in fact, think a lot of folks get tripped up when they try to get too concrete and be too prescriptive in talking about what they want with their family. I recently made a video about this that's talking too specifically about what procedures you'd want, like CPR or feeding tube, can get a lot of folks into trouble, or rather get their families into trouble when they become very sick and maybe they can't speak for themselves. And now families are left with these things that mom or dad said they wanted, like mom always wanted CPR, or dad said he'd be okay with a feeding tube. And the medical team might be thinking, well, I'm not really sure that's in their best interests. I don't think they're going to benefit from that. And now you've got a poor child kind of caught in between with the medical team saying makes sense and something that their mom or dad said that they wanted, and trying to reconcile how to best advocate for a parent. Whatever excuse or reason you need to talk to your family about just generally what's important to you as a person, what living means to you, what quality of life means to you. Put it in writing or don't, but I think giving families a sense of who you are and guidance about your care, and even going so far as to say, I trust you to do what feels right in the moment, even if we can't predict exactly how that will play out. I think that goes a long way. I've noticed a lot of people, parents especially, I think, care less about what happens to them at end of life and more about how their family lives through their death and how that survivorship feels. And a lot of patients I'll work with feel somewhat ambivalent about their end of life care when it comes to just, hospice or no hospice, CPR, no CPR. They want their kids to be okay. And they'll put up with a lot physically and personally, kind of keep the peace with families. And medically, we kind of get bent out of shape about this. And there's a lot of hand-wringing about families coming in and overriding patients' wishes. And that happens, but I'd say it's not as often it happens that patients themselves just, they're okay with their family kind of calling the shots. If, whatever brings the family's peace, they're actually okay with that. It's a different type of autonomy, more kind of relational autonomy, like familial autonomy, rather than individualistic autonomy. That is kind of more the model that we're comfortable with in Western medicine.
And when you were saying there's been spicy debate,
Yeah.
curious on this topic, would you say your answer would be different when we talk about different stages of life? What would your answer be in respect to that?
We draw this kind of distinguishing line between advanced care planning, which is more of the hypothetical conversation about the care you might want down the road with a hypothetical illness, versus a serious illness discussion, which is the types of conversations we're having when we know what we're dealing with, meaning like the conversations I would have in the hospital, for example, when someone is admitted with a pain crisis related to stage 4 cancer. We're no longer dealing with a hypothetical illness. We're dealing with a real one that's having a real impact now. And we have decisions to make about your care now, that how we proceed depends on what's most important to you and what your priorities and values are. And pretty much across the board, we all think that's valuable, both patients, families, clinicians alike. Everyone understands the value of the serious illness discussions. How the advanced care planning discussions, how the more hypothetical conversations impact care down the road when we're in real time, then needing to make decisions in real time. That link has been harder to prove, even though at face value, most people will agree that just talking to family about your wishes is a nice thing to do. It's more about, should we be prescribing this to every person? Does it make sense for every person and every family, to the degree that we are going one step further and saying you need to do this, as opposed to, if you want to do it, here's some guidance on how to have these conversations and where to start the conversation and how to document that, which I think we all pretty much universally agree everyone should have that option and have resources to do that.
And just having the conversation of defining what it means, because I think that helps open up for a healthy conversation. But when there's barriers and you don't even understand what that question is about, what palliative hospice or what you're being asked to answer, it can really put up guardrails into you being able to even answer it truthfully. So I think just having that information, how you've explained it, has been very helpful. For families trying to balance this delicate dance of hope and realistic expectations when it comes to a health issue, a crisis, or, kind of a life-changing event, what would you offer them, or any tips in respect to making treatment decisions when an illness is progressing?
Well, I think it's worth acknowledging off the bat that we can do both. We can hold two things at the same time: the hoping for a cure, the hoping for a miracle, while also planning for things to not go as we're hoping. I think it's important to help folks realize that just making plans, putting contingency plans in place, does not mean that you're betraying your hope. You're not betraying yourself or your loved one. In the same way that, we put on a seatbelt when we get in the car every day, not because we hope to get into a car accident or that we expect to get into a car accident, but because they're common sense precautions in case unexpected things happen. I think that's the big one. And where a lot of people get hung up is feeling like you can only do one or the other. We have to focus on doing everything geared towards cure and treatment, and we cannot think about anything else, regardless of what their expectations are. They don't really want to talk about it. I spend a lot of time with folks just allowing two things to be true.
So when it comes to families and there's children, grandchildren, aunts, and nephews, what resources do you recommend to help them understand and cope when a loved one has a serious illness?
That's a good question. I think we mentioned the conversation project earlier. I think having they have a lot of resources both for patients and for families, for family members who are not the ones living with the illness itself. There's a lot of resources there to help kind of coach. Here are questions you can ask. Here are conversations you can have about just what's going on and what's meaningful to you. And even the patient-facing resources, they're very easy to flip around and ask the person in your family to help have a deeper understanding of what's on their mind and what's going on. But the coping is a very individualized thing. I can take just a lot of time and reflection, and we all have different ways of dealing with difficult times. And a lot of what we do in palliative care is helping you identify how you as an individual cope and how you deal with hard things, and just helping lean into those things, or finding extra resources through your medical team, like our social works, or therapists, and things like that too. Palliative care treats the whole family as a unit, and we treat family distress as much as we treat patient distress. Kind of talk them through what's going on and acknowledging the role they play and the support that they play, while simultaneously just having their own fears and hopes too alongside all that.
And you have the opportunity to be around very intimate conversations, and you're sharing, you get to see, different behaviors on how people are coping in their own way. And when you've been a witness to a disagreement about their loved one, what have you done to navigate those conversations while honoring the patient?
I mean, certainly we deal with our fair shares of conflict in our serious illness discussions. There are two ways that they can play out. The conflict where the patient is still able to express their thoughts, and then the other conflict when the patient cannot express their thoughts and there's conflict about what they would say or think about the situation. In either situation, the big goal is to find common ground and to figure out, what do we agree on? And that can take some work depending on the intensity of the emotions in the room. And oftentimes we do just have to give space for everyone to say their piece and feel seen and heard. And a lot of the anger and the lashing out that we see is often folks up until that point feeling invisible, feeling not seen, not acknowledged. And they've been bottling up that sense of isolation for very long, and it comes bursting out. And try to just give them a chance to be listened to. And so I'll be quiet for a lot of it, just kind of let people say their piece, so long as it's safe and we're not talking about, actual physical violence happening, which is thankfully rare. So a lot of it is acknowledging the emotions first, kind of allowing people to be seen and be given the benefit of the doubt that everyone's trying to advocate for this person in the way that they feel is right, and acknowledging that first and foremost. And when the patient can talk, I'll often say, well, do you want to weigh in on this? What do you think? And sometimes it will, and sometimes it won't. As I was mentioning earlier, a lot of patients, when there's family conflict, they want to keep the peace more than they want any particular type of medical care. And we have to talk about how we're going to reconcile that. How do we attend to this person's needs and their comfort, not just physical, but emotional, spiritual, and psychosocial. In the cases where patients can't talk anymore, they can't share their thoughts about what's going on, I will often ask families, if they could talk, if they could share their thoughts, what do you think they would say? And I emphasize that word say, and I specifically don't ask what they would want, because as I was mentioning earlier, we can get preemptively caught up in the weeds about what they would want, which is very outcome focused, objective focused. And what I'm really trying to do in any conversation is understand how this person thinks and feels, what are their values, what are their priorities, kind of the deeper human stuff. And if we get a sense of that, we get a clear sense of what medical plan best serves those priorities and values. But often people are kind of jumping to, take the ventilator off, don't take the ventilator off, do CPR, don't do CPR. But it's much easier to start from a place of, well, what's most important to this person? What does living look like to this person? What does getting better look like to this person? These are all the things we can do, but what are the things that we should do? And when have we moved from doing things for them to just doing things to them? And most people can come to a general agreement on a person's values and priorities. And that could be a very helpful starting ground, at the very least. We can't always fix a conflict in the true sense that we have, concordance on a plan right away. But general understanding of a person's values and priorities, and allowing everyone to feel heard and have a piece in this person's care, to feel like they're being their advocates, and to be their advocates, not to minimize they are the advocates, is a good starting point, if nothing else.
If you could change how we talk about and prepare for serious illness across lifespan, what's the first thing you'd want everybody to know?
I would want everyone to know that they should ask for a palliative care consult from the time they receive a serious diagnosis, and then we can sort out the rest together. You don't have to do this alone. You don't have to worry about all these things in advance. There's a medical specialty that's there to help you through all this, and too often you get told it's not time for that yet, because medical folks will think that you need to be actively dying to get palliative care, which is just not true. Palliative care has been shown not just to improve quality of life, but to improve life expectancy, improve survival in some cases. And that's early palliative care, like at the time of diagnosis, not palliative care in like the last months of life. I think being able to be a self-advocate to get that palliative care referral will go a long, long way.
Any final advice on how people can better advocate for themselves and their loved ones when facing serious illness?
Well, I'm going to sound like a broken record, but I'd say
I knew the answer, but I had to still say it. I was like, I knew this one.
Yeah, get that palliative care consult.
Yeah.
Be pushy about it. Get the initial referral. If they say it's not time yet, ask them why not. Say, I heard palliative care should be involved at the time of diagnosis. Why do you think it's too soon? Do you think I'm asking for hospice? You might, I never want to advocate like actively like fighting with your doc, but you can push back a little bit. Yeah, that's why I'm here, is just telling people about the straight truth about palliative care, that sooner is better. It's not hospice care. Hospice care is great. I think more people should get hospice too. They are related but separate things, and you can get palliative care alongside all your other treatments.
It's brilliant. I love that. Dr. Tyler, this has been such an important and empowering conversation. Thank you for helping all of us feel more prepared to navigate family dynamics, emotional challenges, and practical decisions with greater confidence. For those who want to dive deeper into these topics, you can find Dr. Tyler through How to Train Your Doctor on social media. And I highly recommend signing up for his newsletter on his website. When you do, you'll get the Goals of Care Jumpstarter, a free cheat sheet that gives you the exact words you can use to start talking to your doctor about your loved one's healthcare wishes. Dr. Tyler also offers private caregiver coaching for those who want more personalized guidance and support in navigating the healthcare system. We'll have all the links in our show notes. Dr. Tyler, any final thoughts for our listeners?
No, just I am so happy to be here and share more truth about palliative care, and thank you so much for having me.
Thank you for joining the show. This was a fantastic conversation, and I just really appreciate all the guidance, all the gems that you drop throughout the show. It's going to help a lot of people.
Thank you.
Thanks for listening to Beyond Clinical Walls. If you learned something new today, please leave us a review on Apple Podcasts or Spotify. It really helps us reach more people who could benefit from these insights too. Hit subscribe so you never miss an episode. We've got amazing content coming, including great episodes with the health creators you love.
You've heard the truth, now take the lead. Stand for yourself, know what you need. One step closer, you've made your mark. Keep showing up and light the spark.